I think we are introducing ourselves at this lecture, which is the talks, which are good. I'm Norma Jo Waxman, and I've been a proud member of AMWA since 84, 85, since medical school. And it was really a life-saving organization to me as a student. So I'm happy to see so many students in the room. I give talks on contraception a lot, and I'm honored to be here at this meeting. I always like to know who I'm speaking to, though. So if you're not a student, raise your hand. Or not a student or resident? Wow, okay, great. And unfortunately, my friend Nancy Church is giving a talk right now on menopause, which I would love to be at, and I'm sure that's where lots of our colleagues are. And I speak on menopause too, but we could flip spaces. We will move forward here. So, moving on, I wanted to disclose Medicines 360s, which you'll hear more about, is a really amazing nonprofit company that was developed by Victoria Hale with the goal of creating an underpriced contraception to decrease unintended pregnancy in the world. They were funded by an anonymous grant and developed a low-cost LNG IUD. Trade name now just got released as the Loletta, and it's going to give Mirena a run for their money because they've undercut the price, and they've partnered with activist Allergen to be their commercial sellers, and they will be selling Loletta. So for the first time, I've allowed myself to be on a speaker's panel because I believe in the product. So that's the disclosure for Loletta. So our objectives in the next 25 minutes are to hope you walk out encouraging with your patients more efficacious methods of contraception, understand some of the current evidence-based guidelines and patient profiles for IUDs. Since there's very few gray hairs in the room besides mine, you've all been hopefully learning this new information, but some of it will be news to others. The CDC and the WHO have come up with some guidelines for us to use that are evidence-based and how to use these with our patients, and integrating current methods such as continuous cycling and quick start. So why do we even need to talk about contraception? Why is it important that we have these talks? I think lots of people think they know. I just mentioned it to another doctor, and they're like, oh, we're all set. We know our contraception. And it's like, well, maybe you do, maybe you don't, but we're not doing a very good job of it. As our last speaker, that was a great keynote, by the way, at lunch. If you missed it, I hope you hear about it later. But he pointed out that contraception is what has allowed us to do many things in the world, and certainly allows women to get ahead. And we know that half of pregnancies in this country are unintended. And that number, I'm assuming this is a light, that number at 52% being desired and wanted is much, much lower if you look at women of color, if you look at poor women, if you look at young women, and if you look at women who are 35 and above, because that's actually 40 and above, the second largest by percentage group of women who have abortions. Because they think they're done childbearing, but they may not be. And we just don't do a very good job of it. So this is people who are using a method that either doesn't work very well, they don't have access to, they have difficulties using it consistently because it's hard to do, or they're just not using contraception. So this is the why. So this is probably, one of my daughters actually said, you can get rid of that slide, that looks boring. But I actually think this is the most important slide in here, because if you go out with nothing else, contraception isn't all equal. It's really apples and oranges when you think of efficacy. And we're going to detail that for you. This is a great slide. I hope you can see it. If you get the slide set, you have the reference at the bottom. If not, you can just Google it. But I have this printed and laminated and hanging in rooms because it goes through really about the efficacy. So we look at 30 and 100, or really 300 and 1,000 women will get pregnant on our less effective methods, versus less than 1 in 100, which is really about 1 in 1,000, 0.1, with our highly effective methods. And he mentioned the term LARC this afternoon at lunch, and you'll hear more about that. In the middle, short-acting or sort of moderately effective methods are the ones that most people think about as contraception. Our friends at Bedsider have done a fabulous job. Do you guys know Bedsider? Yeah. Are you at UCSF? What? Are you at UC or no?
I'm a president at USF.
Oh, awesome. So anyhow, we are working with Bedsider to help put out more evidence-based education for both patients and physicians. I have show and tell, I'll pull out in a moment. But this is a part of a packet that you can get, oops, But it is another great form for people to know. I want to point out our friend the condom. While it's fabulous and needed for STI protection, use it when you need it if you don't have a clear understanding of your partner's history, it is really not a very good form of contraception. So when you look at numbers, this is what we know. And this is why we talk about, or I talk about, apples and oranges, because you can see our highly effective methods, our LARC, long-acting reversible contraception, being the IUDs, copper, and the levonorgestrel, and our implant, which is now, at least in this country, only Nexplanon, as effective or more effective than sterilization. Now, why is that, you may ask, as well? Because sometimes people actually don't have a procedure that takes place perfectly, and they don't go back and get checked. So if your tubal ligation and vasectomy, you haven't gone back at 3 months and seen if your tubes are really blocked or you're not shooting blanks if you're not yet shooting blanks, then you can be in trouble. So these, again, are the hormonal methods we think about, and what we know is that perfect use is not the same as typical use. So what perfect use is what happens when we look at it in studies. So when we do our evidence-based trials, we look at our RCTs, we look at our pharmacologic methods, we know this is what it can do, but this is what it really does. This is what happens in real life. So what happens when you try to put somebody on the pill, which we all think of as, and is the most popular form of contraception in this country, and is a great form of contraception for many reasons, which we'll hopefully have the time to get to. But perfect use is really, you know, about 0.3, so 3 in 1,000 women will get pregnant, but typical use is 9. So 90 in 1,000 women will get pregnant every year using the pill. Okay, and this is why. This was a fairly eloquent trial done a number of years ago now. I can't believe I've been using this slide this long, but nobody's repeated it. But it showed in a college-based, frankly, fairly affluent white college-based population who should have been doing a much better job of this. This is a diary. This is what they were really doing, because there was a chip in their little pill pack that said what they were really doing. And this is what showed the first cycle, about 30% missed 3 pills, 40% the second cycle, and over 50% missed 3 pills in their third cycle. Now, really, they weren't quite fessing up to that. But this is the reality, and this is what we know, which is why we want methods that you don't have to think about, that you don't have to do every day, that are what some, one of my mentors, Dr. Grimes, calls forgettable contraception. So natural family planning is just here to point out that and barrier why this is a great method if this is what you want, because what is the best method for every woman? No. That assumes she doesn't want to have sex. And if she doesn't want to have sex, abstinence is awesome. But for those of us who want to have sex, what is the best method? What she wants, okay? What she wants and when she wants it. And I don't have time, unfortunately. I left it in the slide deck, the counseling, the tiered counseling effectiveness methods, how we find out what she wants is really important, part of what we do. Another talk maybe sometime, and not when you have 20 minutes, but yes, what she wants. MMR, this is our tool, this is our guide, this is our guidelines, this is our God now of contraception, started with WHO and now the CDC. And we have a way to do a classification. How many people are aware of the CDC MEC, WHO MEC? Wow. Awesome, not many, this is great. Okay, so I will try to get a handout to you showing you this, but 1, 2, go, 3, 4, no is the classification. So 1 is not only the method is safe, it's to be used as treatment. So if you got anemia, you can use the pill and it will treat your anemia, right? If you have ectopic pregnancy, you can use the IUD because it decreases your risk of ectopic pregnancy. Class 1, not forbidden anymore. 2, use the method, it's generally safe. 3, think about it, it's really probably not a good idea and there's other methods that are better and safer. Sorry, did I put this too far away? Maybe I should stop wandering. And 4, no, don't use the method, it's not safe. So the CDC has a color handout that you can get. It is basically all along the sides what the different medical conditions are. It then has initiate and continue, and then has the numbers. Oh, is that better? Yeah, okay. And then, as I mentioned, along the top would be all the different methods. So here's your combined, this is your estrogen-containing methods, right? Combined pill, patch, rings have estrogen, progestin-only pill, injection implant. I'm going to hold questions to the end, unless it's something like you're drooling. Or...
I was just going to ask if this is the same as the app.
Yes, and thank you.
Okay.
Thanks. So do you have your app?
I do have the app.
Woohoo! Okay. So this is my friends at RAP, which actually this still says WHO. It should say CDC, and this is where you can get the one from the Reproductive Health Access Project. And if you don't know about RAP or the Reproductive Health Access Project, I invite all of you guys to look them up afterwards. But this is their color one that you can laminate and have on both sides as a reference all the time. And this is our friend in the third row mentioned in the app, okay? This is the handy app the CDC came out with. Everybody should have it on their phone. So not only do we have the CDC MEC guidelines, now last year released were the SPR guidelines, which is how and when to start, what do you do if you miss a dose, how long do you need to use backup, all of the extra stuff that wasn't in the first round, okay? So let me check my time here. I think we have time enough. Yeah, I'm going to quickly go through this because it's sort of fun, since you guys seem to not have heard of the MEC before. What if 3 of these women can safely use an estrogen-containing method? What about a hepatitis carrier or mild cirrhosis? What do you guys think? Yes? No? You're not going to say. Okay. Migraine without aura in a woman over 35. We know if she has aura, no. Absolutely no in anyone. But what if she has migraine without aura if she's over 35? Is that safe? Estrogen-wise? No. How about breast cancer in mother or sister? Is that safe? Breast cancer in mother or sister? Why not? Oops. Come back. How about migraine with aura? We said no. Okay. Breast cancer in mother or sister is not a contraindication. Okay? In fact, if you have BRCA, if you are a BRCA1 carrier, what is the first thing we're going to do for you if it's one of you guys in this room who may still want to hang on to your ovaries and your eggs for a little while until you can figure it out? We're going to put you on the pill. We're going to stop you from ovulating. So not only is it not a contraindication, these are methods that are safe in our treatment, okay? Please take this home, because not only did you not know, trust me, your patients really don't know, okay? So what about a family history of DVT? What about a blood pressure of 145/95? Well, she's got a treated blood pressure. Is that a problem? Yeah. Okay, she probably shouldn't be using estrogen. That's a class 3, okay? What about family history DVT? Okay, shouldn't be a problem if it's like they were on a long flight and they had their DVT or they had surgery in their DVT. If their family history of a clotter, that's a whole different story. Smoker over 35? No, okay. All right, so we did this slide. So I just want to point out again, my big LARC plug, is that in all of these situations, breastfeeding, hypertension, smoking, migraine, liver disease, any of our LARC methods are safe because it's copper or progestin, right? All right, so we're going to do the run-through of the methods. And I should have warned you all at the beginning to hang on to your seats because this is really a 45-minute talk and we got a half hour. So, but the long-acting methods are the IUDs. And we used to just have 2, right? We had the copper IUD, which goes under the trade name Paragard, and the Mirena, which are levonorgestrel, which was released in 2010. Since then, a couple years ago, Mirena's little sister Skyla came out, which is a 3-year method and has 13 micrograms instead of 20 of the levonorgestrel. And just the last month, Loletta was released. And you guys probably haven't heard about it yet because it just got FDA approved, but is essentially identical to the Mirena. It is labeled for 3 years, study ongoing for 7. So when we think of these methods, both of them, both the copper and the levonorgestrel IUDs, have a decreased risk of uterine cancer, okay, thinning of the endometrial lining, and an immediate return to fertility, right? The Paragard, labeled for 10 years, good for up to 20. It's a wonderful option for women who are older, who are perimenopause, they don't really want to, have more kids, or if they have other medical complications in their lives, the Paragard's always a great method. One of the things that we do need to know and warn people about is that it may increase their bleeding. So they may have increased bleeding. That's particularly true in the first 6 months. The levonorgestrel, what can we expect and what do we need to help our patients understand so they're not worried? Oh gosh, I'm sorry. Can you guys hear me when I walk away? No. No? Okay. Good. That's the kind of thing you need to tell me. When you walk away from the microphone, no. When you have a levonorgestrel IUD, you will see some initial spotting. That's predictable, all right? And it's not a problem, and it's not dangerous. And if you warn women that they're going to have that with their methods, whether it's the pill, the patch, the ring, the IUD, the depot, then they're less likely to stop their method or want to stop. And they're less likely to worry. So let them know. And then eventually with the levonorgestrel IUD, you have significant decrease in blood loss, and in fact, it's a treatment. All right? It's also a nice option off-label for use with estrogen therapy for transition to menopause. Suspect my friend Nancy Church is talking about that. We know it shrinks fibroids and decreases risk. So the big take-home that's different than 15 years ago is that neither IUDs cause STIs or infertility. All right? The device is not a problem. Chlamydia is a problem. And untreated chlamydia is what causes tubal infertility. So untreated and undetected chlamydia, because most people don't know, like less than 20% of women know if they have chlamydia, is what has been linked to the history. Now the device that got taken off the market in the 70s, which took the downfall of IUDs in this country to barely nothing, we're now back up from less than 1% to 12%. I sort of want applause of that. But that's been an exciting move in the last 10 years, but that was because of a bad device, the Dalcon Shield. So it's not the IUD in general, but the Dalcon Shield had a multi-filament string that hung into the vagina and caused infection. What we see now is that if you have an infection and you have an IUD in place, we can treat you with the IUD in place. We don't have to pull it. We don't change treatment. Don't need to treat for actinomycosis. And the transient increased risk during placement is only because if people aren't screened, or if they're not treated after screening, or if there's contamination, okay? More IUDs myths that we are debunking is that this was once thought to not be a safe or okay method for teens. Most of you now in medical school hopefully are being offered that as a first-line method. We know ACOG and the American Academy of Pediatrics have both released position statements on this. Incredibly important move. The noontime speaker spoke about my friend's project in the Choice Project in St. Louis, which was incredibly successful, unbelievable results, which we didn't expect. 10,000 women, they saw a decreased rates in pregnancy, abortion, and it just has been amazing when you offer every woman for free these methods. All right? IUDs don't cause abortion. I think I mentioned STIs. I already put a plug-in for safe with ectopic, anytime in the menstrual cycle, safe for women with HIV and postpartum. Nexplanon is the implant we have currently on the market. It's a 3-year method. It's placed in the arm by a provider. Super easy to place. Very, very effective. Pretty much, unless you're pregnant when it's placed, you're not going to get pregnant. The few cases of failure we've seen have probably been that there was, in that within 10 days the pregnancy test wasn't positive yet, but they were already pregnant. Inhibits ovulation is its mechanism of action and thickens cervical mucus, both. And again, like the levonorgestrel IUD, because it is a progestin-only product, unpredictable bleeding, all right? We can warn women, we don't know. I call it the AFib of contraception. It is irregularly irregular, okay? So what are some of the non-contraceptive benefits of the levonorgestrel IUDs and implants? Well, we know that they decrease bleeding, so they decrease anemia. Not only do they do that, they decrease pain. So they will decrease your fibroids, they'll decrease endometriosis, they'll decrease any kind of dysfunctional uterine bleeding pains that women have. I did throw this in here because I knew I wouldn't really have time to do counseling, but I love this slide so much. A colleague of mine, Patty Kaysen, who I speak a lot with, uses this. Instead of saying place, or say place rather than insert. Insert's sort of scary, right? We're sticking something in. So we place the IUDs, we place the implant. So try using that language. And instead of saying that you have this for 10, 23 years, people want to have that flexibility. These devices are good up to. And when you want to get pregnant, you come in and we'll remove it. And your ability to get pregnant will return to what it was, okay? Just the language we use. All right, instead of long acting, that's sort of a weird one. Top tier, the most effective. This is what most women doctors use. Okay? So just to wrap up the LARC section, first line, same day placement, I didn't talk about that, but this is so important. operationalized in the clinics and offices you work in, I don't really care. You know, the get a pregnancy test and chlamydia GC testing and come back in 2 weeks, who cares what those tests were 2 weeks ago? I mean, frankly, she could have had sex with I don't know how many people in between. And the reality is the day that you place, is she pregnant and does she need to be screened? So our second line, second tier, we have the Q3 month method. So progestin-only depot is still around and is still an awesome method. It was released in the 90s. Again, irregular bleeding expected. Amenorrhea, people will not bleed, which for most of us is a good thing, and as safe. The advantages is it's private. People don't have to have pills or things at home. They don't have to have a thing under their arm. They can go into the office and they don't need to know. So there's many cultural reasons why women need to have privacy. They've just really done childbearing and either their family or their partners are really not up for that. They can come in and have this. The side effects that we need to be a little concerned about are that of all the methods, this is the only one that we know of that can cause weight gain. Not everyone will gain weight, and there is some predictability about that. The studies show that if you've gained weight at 6 weeks and at 6 months, then you're going to continue to gain weight. So bring those women back to check out and talk to them about that. We also want to make sure that this is not somebody who says, you know, she's a resident or a fellow and, you know, like one of the doctors said, on May 1st, I'm going to have a baby. This is unpredictable return to fertility. All the other methods you stop, and if you were ovulating before, you're going to ovulate again. This method, it may take 9 months to ovulate, okay? Monthly, Nuvaring. So I think if you look at the family planning world, which is where I live, and talk to women providers and OBGYNs, even though I'm family medicine, if they're not using an IUD, this is what they're using, okay? The ring is a great method. 3 weeks in, 1 week out is how it's labeled. However, I'm going to point out that there's alternative off-label ways to use it. It's continuous cycling, rarely noticed during sex. You have to be able to put your finger in your vagina and insert it. If not, you can use a tampon tube. Somebody also just came up with an applicator insertion. It bypasses, you know, it doesn't go through the liver, right? Bypasses first pass metabolism. So that is a great benefit of this method. And the other super nice thing is that the serum estrogen levels are very stable, okay? So for women who have mood fluctuations or headaches or things with their pill, because we know there's a spike every day with a pill, you have a steady serum state. And it's good for 35 days. So you can do the first of the month or just for 4 weeks, all right? Calendar month. The weekly patch is still around, is still a great method, higher estrogen levels. And then there's our pills, all right? So many, many different formulations. When we think of a combined pill, we have an estrogen and a progestin. It's traditional 3 week on, 1 week off, frankly, is flawed and was for historic reasons we don't have time to get into, but we now have lots of extended cycle options. So we have seasonal, seasonique, which are 3 months on, 1 week off, and they're generic sisters. We have Librel, which is the full year, which is Amethyst, is its generic trade name. I highly recommend learning a few of those and using them. The 24 3-day cycles are also awesome, and those are what we call shortened hormone-free intervals. So like Loestrin and all of its generic sisters. Progestin-only pills, sort of a forgotten but very effective and useful method, especially for women, I find, with migraines, those 35-year-old smokers or the 35-year-olds with migraines who may want to get pregnant soon and don't want a long-acting method or just need a steady state serum level. This works super well. Got to take it every day, though. And I just mentioned the extended cycle. Instead of just being convenient and not bleeding, because there's no need to bleed, they're increased efficacy. Okay? The extended cycle methods, whether you're using the 3 months on, 1 week off, or the 24 3-day cycle, have a higher efficacy rate, and this is why, because your follicles are not going to pop out. And more importantly, when do people feel crummy when they're on the pill? It's not when you're taking the pill, it's that week you don't take the pill, right? So it's that withdrawal bleed time when people have symptoms. And as I said, there's many dedicated products. I love this slide just to point out, do we need to bleed? No, there's no need to bleed. And is menstruation normal? Well, this is what's happening today, about 450 cycles in our lifetime, if we're not on something that makes us stop ovulating. And colonial America, they were either nursing or pregnant most of their reproductive years. So I'm going to wrap up with the last couple slides, and then we have a few minutes for questions. OCP's big benefits, besides the anemia and acne, most importantly is our breast cancer and ovarian cancer reduction. All right, ovarian cancer reduction by 80%, and that's long lasting. So if you use the pill 10 years in your adolescent, early 20s, that's going to help you out in your 40s. No increased risk of breast cancer, fibroadenomas, and then again, just driving home, what are people afraid of? Okay, look at the risk. This is a 30 microgram pill, and this is this woman's risk of dying. This is a non-smoker under 35. Yeah, I mean, maybe we don't skydive, except for my older daughter who wants to, but driving a car, getting in a bicycle, pregnancy, these are dangerous. We don't tell people not to get pregnant because they're going to die. Give more pill packs, quick start. I didn't get to, but you basically don't have to wait till Sunday or her next period. Start anytime, any day. A former AMWA stalwart, Carolyn Westoff, was really the originator of this idea, and now it's been studied in all of our methods. And there are permanent methods, and I just want to show you, this is more bedside stuff, resources for providers, for patients. Lark First, this is the St. Louis study. This is all available now online for you to set up in your clinics, in your universities. Lark First. I took a picture of them this morning. I was so tempted to add it on, and I thought then they'd be really mad at me. So, any questions?